Hi, hello. Welcome to another episode of the lecture series on management of medically compromised individuals in dental practice. And today we're going to discuss about certain different conditions. Myself, I'm Dr. Epan Thomas. I'm the professor and PG guide in Department of Oral and Maxillofacial Surgery, Pushpagiri College of Dental Sciences, Tiruvalla, Kerala. Today we're going to discuss about diabetes mellitus, a condition which is actually characterized by abnormal levels of blood glucose in the body. So this abnormal levels of blood glucose and its various implications on the system, all we are going to discuss today. It's probably one of the most common endocrine disorders affecting the human population, with the extent of injuries on different systems in different ranges affecting one's quality of life, the way what one has to do, what are the complications associated with this diabetes mellitus, how each organ of the body is going to get affected with this diabetes. It's a big detailed part what we're going to cover today. And this diabetes mellitus, it's got important relevance in the current scenario because especially in this post-COVID situations, most of the patients which are treated with COVID disease, who has been treated in the hospitals with COVID disease, has been shown to be having an abnormal high levels of blood glucose. Even normal individuals were detected with high levels of the blood glucose in the body. And even diabetic patients, as you all know, they are having a lot of comorbidities and they're very well immunocompromised. So they do have a tendency to get more prone for these COVID infections. And these type of post-COVID treated patients nowadays come to a clinic for dental treatments. So one should have a proper understanding about all these situations. So that is the importance of the diabetes mellitus. It's got infections on various other systems along with other disorders also. And I'm sure this is one of the most common disease among the human population, one of the most neglected and the overlooked conditions in the human population, where the patients themselves do not have much sort of a seriousness about the incidence of this diabetes mellitus or the rate at which this particular condition can affect your system. Okay, now let's move on to what actually is diabetes mellitus and what are the details. As you have told earlier, diabetes mellitus is an abnormal high levels of blood glucose in the level which has not been controlled and then leading to a lot of infections and associated problems. Now, WHO in 2019 has classified diabetes into different types, into 6 types. Okay, the type 1 diabetes, which actually is quite less when compared to type 2 diabetes, it is called insulin dependent diabetes. It occurs about 5 to 10% of those patients who's having diabetes mellitus. It is actually an autoimmune disorder where the body's own cells, identifies our own pancreatic cells. The islets of Langerhans are being identified as an attacking organ or attacking antigen, and the body's own cells destroys these islet cells of Langerhans. It's called an autoimmune reaction, an autoimmune response by the cytotoxic cells of our own system kills this or destroys this pancreas and the islet cells of pancreas, and there's absolutely no production of insulin. When there is no production of the insulin, the levels of blood glucose remain high. Okay, so this is actually called as juvenile diabetes or insulin dependent diabetes, and its occurrence is quite less. It's about 5 to 10% of the total cases of diabetes mellitus. Now let's see what is type 2 diabetes. This is the most common form of diabetes, what we all see around. It occurs for about 85 to 90% of the patients who's having diabetes mellitus. Okay, it's also called as non-insulin dependent diabetes. The reason being, now this particular condition, the type 2 diabetes, there is no autoimmune reaction. There is formation of insulin. There is secretion of insulin by the islets of Langerhans, but the blood glucose is resistant to the actions of insulin. So if the insulin doesn't act, insulin is the hormone secreted by the pancreas, which actually lowers the blood sugar level and always maintain it. And the other hormone is actually glucagon, which actually elevates the blood glucose level whenever there is a drop. So this balance is always maintained in the system. A balance between insulin and glucagon actually maintains the blood sugar level. So whenever there is a high blood glucose level, this in type 2 patients, type 2 diabetes patient, even though there is insulin production, the insulin is resistant to this blood glucose. So you can't control the blood glucose level. So the hyperglycemic situation remains as such it is, and that is the reason for this type 2 diabetes, which is actually seen in 85 to 90% of those patients with diabetes mellitus. It's also called as adult diabetes, or it is also called as non-insulin dependent diabetes. As I've told you, type 1 is insulin dependent diabetes or juvenile diabetes because it's usually seen in the teenagers or the ages in the juvenile group. Okay. Now there's a third variety where we call it as hybrid type of diabetes. Now, the immune related or the type 1 diabetes I've told you, it's usually seen in young individuals or in the juvenile group. So that type of diabetes where this immune mediated destruction of the pancreas and diabetes seen in adult onhood is actually put as under hybrid variety. Okay, and in type 2 diabetes where there's a prone or there's a ketone prone type 2 diabetes is also put under your hybrid diabetes. So the adult onset immune mediated diabetes and the ketone prone type 2 type of diabetes is classified under hybrid diabetes. Okay, now let's see what is the specific type of diabetes. Now this actually is occurring or happening because of a genetic mutation. Now if there's a genetic mutation either in the islets of Langerhans, okay, where the cells cannot produce insulin, or where there's a non-immune mediated response. So the genetic mutation creates a non-functioning pancreatic islet cells. That can be one cause. This particular genetic mutation can actually cause a defect in the function of the circulating insulin. So insulin, even though it's there, it is not functional. Okay, that all comes under specific type of diabetes. And this infection related diabetes, sometimes you have seen chronic infection can give us where abnormal blood glucose level because of the alteration in the carbohydrate metabolism and the endocrine imbalances. So those type of infection related diabetes mellitus. Drug related diabetes mellitus, patients who are on long terms of steroids, because of this abnormal hyperglycemic effect of the corticosteroids, they create a diabetes situation. So there's diabetes arising from the use of long-term drugs and specific infections and other chemicals mediated, other disorders of other exocrine glands. Now all these comes under the specific type of diabetes mellitus. Okay, the next type is pregnancy related. As we have seen, as part of the gestation, you have the gestational diabetes. The levels of blood glucose go high because of the hormonal imbalances during the phases of pregnancy. So that is pregnancy related diabetes. Okay, then the last one is unclassified type of diabetes. In this unclassified type of diabetes, actually any diabetes mellitus or any abnormal blood glucose level arising for which we can't find any reasons, for which we can't put them in type 1 to 6, any of those categories. So any diabetes with no known reasons is actually put under unclassified diabetes. I hope now you have an idea, okay, of this complex disease and the complex nature of classification given by WHO in 2019. Now, why I'm telling you all this is basically because we actually have a feeling, okay, we are a dental surgeon, okay, we don't have to know that much about these medical conditions. We don't have to know about all this because the laboratory will give us report and we just have to follow it. No, that is not right. Because in the current scenario, when we are all working with these people and we are all healthcare providers, so one must have a proper understanding of all these diseases which actually patient reports to one clinic with. Because I personally and strongly believe that almost all the complications which is arising in dental practice, at least 80 to 90% of the complications which arises in dental practice are because of a non-proper management of the patients, the medically compromised situations. In other words, patients with medically compromised situations are the most common candidates which is giving us trouble or which can cause complications in dental practice. So proper understanding of all these medically compromised situations, the pathophysiology, how this disease happened, how it works, what are its effects on the system, why is it causing trouble for us in dental treatment, what are the things that I should keep in mind, what are the things of the investigation part I should take care of this patient, should I actually manage this particular patient. So you should have an overall overview and in detailed knowledge about these common conditions which actually report to your dental clinic for treatment. So that is the importance of knowing all these basic things, and of course the pathophysiology and all those I've already explained. So all these are very much significantly required for anyone, whether we are a dental practitioner or we are just supervising the clinic. But whatever it is, if you're providing healthcare, if you're providing dental treatment to a patient, you must have a detailed knowledge about this, because lack of awareness of the problems associated with diabetes will never give us immunity in case if any litigation arises and we are actually called or to appear in the court of law. So let us actually be a bit more cautious about it. Let us be more practical. Let us prepare ourselves so that any patient who goes against us in the court of law, if they take us to the court of law, we should be actually planned very well in such a way that all our treatment plan should be based on the proper planning and assessment. So this is the basic reason I am explaining these details to you also. Now that we know the classification of diabetes, now let's move on to what are the problems associated with diabetes mellitus. Now, any systemic disorder, what the patient reports to you, one should have an understanding about. You should see in 2 or 3 different headings. What are the problems associated with this particular condition? Why this particular condition patient requires a special care in providing dental treatment? Why I should be more cautious about dealing with these patients? Now, those are the reasons what I would put it under problems associated with that particular condition. Then, in the second part of we should be knowing about is about the investigation. What are the investigations that I should be doing in such medically compromised patients to make myself and to make the patient comfortable and to make sure the patient is safe and can be taken up for treatment? That's the investigation part. And after knowing the investigation and the values and the safe limits, then the management part. How should I modify my treatment plan? How should I manage this case to avoid complications in dental practice? So 3 heads: problems associated with all these diseases, the signs and symptoms and the investigation part, and management of this disease. Okay, so I will be describing under these headings like I've told you earlier. Now let's see what are the problems associated. Number 1, the patients with diabetes mellitus have got a compromised immune system. As you all know, the immunity or the immune system of one's individual is purely a measure of the leukocytes or the neutrophils and the lymphocytes. The WBC cells are actually contributing the most important part of the immune system. I've told you, now these diabetic patients over a period of time when they are chronic diabetes, their immune system become weak because these leukocytes are, the functions of the leukocytes come down. They become more and more defective. Now any infection, when any antigen attacks our body, now these WBCs, the primary cells are the neutrophils, and then chronic inflammatory cells are your lymphocytes. So the first line of defense is your neutrophil. So once the neutrophil goes there with a strong armamentarium and all sort of equipped, meets the antigen, fights against it and win the battle, the disease gets controlled and your body's immunity takes care of you and protects you from this particular infection. Imagine a situation where your frontline defense warriors, that is, these WBCs and the neutrophils, are weak. So when they are weak, what happens? Any antigen which is affecting us or attacking us has got a dominance. So they are likely to win the battle against our own defective WBCs. So what happens? The infection predominates. The infection or the antigen has got a more domination. So that is the shift of balance. So that is what's happening in diabetes mellitus. When they have a defective WBCs and this neutrophils, the frontline warriors are very defective. So any attacking antigen has got a chance to win the battle, and then that is the reason they are more prone for infection in these individuals. Okay, I hope that is clear for you. Now, as part of healing, the normal process, as you remember, the process of inflammation, your healing, repair, all goes hand in hand. And in the normal situation, when we have studied that in the blood volume, the blood fluid, all these formed elements and the plasma are going in a smooth laminar motion. Okay, well, WBCs, RBCs, platelets, all these in this particular blood as over the plasma is going in a laminar flow. Whenever there is an attack by an antigen, whenever there's in the phases of repair or inflammation, there is a first step. What happens? All the WBCs from the central laminar flow, they move towards the basement membrane. It is called as margination. When it comes to margination of the, when it comes to margins of the lumen of the vessel walls, that's called margination. It just gets pavemented there, like in a line. So margination, pavementing. Then it crosses across this blood vessel walls and comes outside, what we call it as diapedesis. And then this has to move to the particular site where the demand is required, where the action is happening. When that attacks the cells, kills the cell, phagocytosis, macrophage formation, all those things. That is a sequence. So imagine if the WBCs are weak, all these phases gets delayed. Okay, so what happens? The process of healing gets delayed, and that is the reason why they have this delayed wound healing. On top of this, the end phase of healing is a mature, collagen formation. This collagen formation is essential for any good wound to heal in its proper strength and quality. So this collagen is formed by the fibroblasts. These fibroblasts are quite defective or immature in diabetic patients, whenever they are formed. And there is more amount of fibroblastic disruption, or destruction, what we call it as apoptosis. Now these are situations which actually kills this, reduces the efficiency of the fibroblast, and the resultant collagen formed is immature, and there's a delayed wound healing and a defective wound healing. So that is the reason why you have an infection, they are more prone, why they have a delayed wound healing. Now let's see what's the other big problem with diabetic patients. Microangiopathy. You might have heard this terminology. In these individuals, in diabetic patients, they always have this high blood glucose level. The circulating blood has caused always a high blood glucose level. Now this glucose, what happens? They get adhered to the lining of the vessel wall or the basement membrane of the vessel walls. The glucose get adhered to that. They get, connected to the basement membrane at the endothelial cells. They slowly proliferate there and slowly, destroy these endothelial cells, and there is proliferation and secretion of these contents there. And just on the surface of the endothelial lining, slowly they form plaques. Okay, the small plaque formation gradually build up, and that is the reason these patients with diabetes mellitus have got more tendency for atherosclerosis and this plaque related coronary artery disorders. Now microangiopathy is nothing but when this plaque gets formed on the inner lining, so the vessel wall diameter becomes less and less. Okay, the lumen size becomes less and less. So amount of blood going through that becomes less and less. The quality nutrients and all other vital structures or vital substances passing through the blood vessel become less and less. So that situation in which the vessel wall lumen becomes less and less because of this gradual secretion, gradual collection of the glucose in the basement cells and the proliferation leading to that is called as microangiopathy. This microangiopathy can affect any organ of the body and bring about lot of destructive changes. Microangiopathy, when it involves your eyeball, when it involves central artery of the retina which supplies eyeball, we call it as your diabetic, retinopathy. Okay, then when it affects all these peripheral nerves, it's called peripheral neuropathy. When it affects the kidney, we call it as diabetic nephropathy. Similarly, it can affect the heart and bring about increased incidence of atherosclerosis and coronary artery diseases is the end result. So this microangiopathy has got a lot of effects on all the organs, like I've told you. Same reason, there's a vascularity reduction, so all these nutrients are also less. That again adding to our existing problems. So they do have a tendency to have a reduced functioning kidney, which is very well, it should be kept in mind when we prescribe drugs. They do have a tendency for, atherosclerotic plaque and associated cardiac problems and coronary artery diseases. Again, we have to take care of that patients and deal with matters, how to deal with patients with coronary artery disorders. That's another one topic. Okay, and because of the microangiopathy and the reduced lumen, and the vessel wall thickening, the pressure exerted by the blood volume on the vessel wall is more. That means hypertension. So these are the common associated problems in patients with chronic diabetes because of the microangiopathy. They do have a tendency for heart disorders. They do have a tendency for your kidney disorder. There, when you write prescriptions, you have to be careful. Should not avoid using nephrotoxic drugs. Same way, they do have a tendency for hypertension. So all the associated diseases and disorders also you should keep in mind when you think about patients with diabetes mellitus. Associated systemic disorders. I've told you just now, all these patients with chronic diabetic mellitus, or most of these patients, they have this tendency for having cardiac disorders and diabetes mellitus and other renal disorders. So we also have to think about these patients with such disorders and take the necessary steps to prevent problems associated with that other disorders. Drug interactions is yet again another one problem associated with diabetes in certain type of oral hypoglycemic agents. Patients who are on oral hypoglycemic agent, especially with your sulfonylureas, okay, they have a strong drug interaction with this when patients are given benzodiazepines or anti-anxiety drugs. They actually prolong the duration or intensify the action of these oral hypoglycemics. Patient can go into hypoglycemia. They also do have an association and interaction with NSAID. So prescribing these drugs has to be used with caution. Hypoglycemic syncope is another one problem associated with this diabetes mellitus patient that one has to be prepared in a dental clinic. Now the reason being, now patients who are on chronic oral hypoglycemic agents, they are regularly taking the medicines to control their blood glucose. So morning they have taken the medicine, okay, so they have the strong action of the drug which lowers the blood glucose. They might have taken the food also, that will be there for 1 or 2 hours in the stomach, or I'm not talking about the overall gastric emptying time, which is 4.5 to 5 hours, but from the stomach basically it gets cleared in 1 or 2 hours. So after 1 or 2 hours, what happens? There's no content in the stomach, but the drug, the hypoglycemia effect of the drug will still continue. So that will lead to a hypoglycemia. When hypoglycemia comes, like oxygen, glucose is equally important for all the vital structures for the survival, which includes the brain. So a hypoglycemia can cause a syncope, like your vasovagal syncope. Okay. Then another one reason for hypoglycemia is, now these patients sometimes, considering they might have heard, okay, dental treatment stress, they might be a little apprehensive, they might feel, a little worried, they might take this medication more than what is required normally to meet the stress of the dental treatment without our prescription. They are all these patients, they do have this system, or they do have the habit of self-medication. So they might be taking, extra drug, extra hypoglycemic drug. So that again leads to a severe drastic drop in the blood glucose and resultant syncope. Okay, that's about the oral hypoglycemic drugs and the hypoglycemia related syncope. So one has to be prepared. One has to have identified this particular condition whenever it happens and do the necessary measures. I'll come to that later, and to deal with situation. So you have to keep all these things in this mind. Whenever you're using local anesthetic with adrenaline, remember all of us are using local anesthetic with adrenaline. Now, the problem with adrenaline is adrenaline has got an effect to bring or elevate the blood glucose level. Adrenaline is a strong hyperglycemic agent. Okay, what I mean by hyperglycemic is adrenaline, by virtue of its effect on the your carbohydrate metabolism, increases the blood glucose level. Okay, now it actually increases the blood glucose level by three main mechanisms. It reduces the peripheral utilization of glucose. Whatever glucose is coming, the cells and all use it, and that's how again the values of the glucose is coming down. So this adrenaline reduces the peripheral utilization of glucose. What happens? The net result is an increase in the blood glucose level in the blood circulation. Okay, it actually promotes gluconeogenesis. From non-carbohydrate sources, it actually induces formation of more glucose. So again, giving rise to a hyperglycemic situation. Okay, and it also promotes glycogenolysis. So by glycogenolysis, the glycogen is broken down in the liver, and again the end product is glucose, thereby blood glucose level increases. So that's the effect of adrenaline. So these things has to be kept in mind, and these are the problems associated with diabetic patients. You might have thought, what was there? Nothing was there, isn't it? But now, just after listening to my this much part, you might have understood, at least you might have had an idea about how complicated this particular disease is and what all problems that one has to be worried about, and you have to keep in mind whenever you take a patient with diabetes mellitus. Remember that. Now, having known these, problems associated, let us see what are the investigations, what is required to ensure the values are within normal limits, or to ensure that the patient is fit for the procedure. The first and foremost thing what we'll see is the random blood sugar level. Now, when you talk about random blood sugar level, the value should be always less than 200 milligrams per cent. As per the WHO classification of diabetes, a random blood sugar level more than 200 milligrams on one or two multiple occasions is considered to be a diabetic patient. So make sure the value is a diabetic patient. The random blood sugar level could be less than 200 milligrams. That again, but then when you think about random blood sugar alone, remember just to take history of the diet what the patient has taken just before testing the blood sugar, because a high caloric or high sweet diet can actually raise the blood glucose level also. So do not actually completely rely on random blood sugar alone. So that is where your fasting blood sugar level should be actually clubbed with your random blood sugar level. Okay, the fasting blood sugar value as per the WHO, 126 milligrams per cent, 126 milligrams per cent is the cutoff value for being classified as diabetic patients. Any value less than 126 milligram, they call it as the pre-diabetic stage up to a value of 110. Okay, so any value more than 126 milligrams per cent is considered as a diabetic patient. So in a diabetic patient, if the patient is on oral hypoglycemics and then values up to within 140 milligrams, you can take the patient for a dental procedure. No problem with taking such patients. Second, the other one thing what you have to look for is the postprandial blood sugar value. That again, the value should not exceed 200 milligrams per cent as per the WHO recommendation. Okay, postprandial blood sugar means a patient after taking a nice meal or having taken some sugar diet, whatever it is, 2 hours after that, when you check the blood value, the value should not exceed 200 milligrams per cent. HbA1c value is again a reliable value in terms of knowing the patient's value or whether the glycemic status. That actually gives you an idea about the immunocondition of the patient more than the other above reported three values. Why? Because the other three values, the random blood sugar level or the fasting blood sugar level or the postprandial blood sugar level, gives a value of the blood sugar in the system at that point of time. Whereas the HbA1c value is a measure of the glucose content in the RBCs. Now the glucose is existing in the RBCs in the glycated form. Okay, this glycated glucose is actually the RBCs are the one which carries along with the the oxygen. This blood glucose is also being carried by the RBCs to different parts of the body, including all the vital structures, and the blood actually takes up, the organs takes up this blood glucose from the RBCs. Now an RBC lifespan is 60 to 90 days is an average lifespan of the RBC. So a measure of the RBC for the glycated hemoglobin, that is the HbA1c level, actually gives you an idea whether the patient's diabetic condition is stable or not, whether the patient's diabetic condition is uncontrolled or not, whether the patient is safe to be taken up or not for a dental procedure. So an HbA1c value less than 7% is considered to be safe for dental procedures. Okay, so that is something what we have to keep in mind. So all these values has to be within normal limits. Now that doesn't mean that any value beyond this cannot be taken up. What I am talking about is the most safe values that one can be taken or dealt with in the dental clinic. Now if there's an abnormal increase in the levels of the blood glucose, even within normal limits, normal range of abnormality, the patient can be taken up in the hospital setup where the doctor, the physician or the diabetologist or the endocrinologist sees the patient and maintains the blood glucose level to a normal condition, and then also you can do the procedure. So these values are ideal as far as clinical setup is concerned. Any value above this or higher values should be taken up in the hospital and should be treated if it's emergency under the observation and the recommendation and consent of the treating doctor. So I hope all the values and measurements are understood. Now let's see a patient coming to you, in your clinic, and you've actually taken the history and you have an idea about, okay, this patient is taken medication, and so I should be looking out for the possibility of a hypoglycemia, and I should be well prepared in case the hypoglycemia rises, and I should prevent further worsening. Okay, so what are the things that, if you know, what are the things you should look for in a patient who's a diabetic patient? What are the things for hypoglycemia? Because this is a complication which can arise, a hypoglycemia syncope. So this also can be, seen and diagnosed very early stage itself, so that you can prevent the syncope associated with this hypoglycemia. So what are the signs? Let us see. sweating. Patient start, minimal amount of sweating in the your forehead area, your malar area, or the cheek area, the tip of the nose, the chin area. All these, slight droplets. Even if we put a AC, patient might start slight sweating, because these are all the signs of the protective or the compensated sympathetic mechanism which is coming into picture. Then tachycardia, again, as part of the sympathetic mechanism, the heart rate goes high in an attempt to increase the blood supply to meet the hypoglycemic situation. Increase anxiety, they will be having more hyper, they will be actually having a bizarre behavioral pattern. They don't know, they're not responding very well, their judgment is not correct, they're not answering to you properly, they're just giving all, very answers which is quite bizarre, and their pattern is quite different. And they actually, a patient was actually in the cooperative in the first part, then gradually becoming uncooperative. These are all the early signs and symptoms of hypoglycemia. Now, at that particular point of time, if you ask the patient the details, whether the patient has taken medication, if they're taken his food, then if the patient is not taken food, then definitely you can understand that patient is going for a hypoglycemia syncope. Okay, and if you are not identified that at that particular point of time, what happens? Then the later stage, what happens? Patient goes into syncope or unconsciousness, then seizure activity because of this lack of vascularity and the oxygenation, hypoxia and hypoglycemia, hypotension because of a reduction of the blood volume and there's a reduced venous return, and hypothermia because of a lack of reduced circulation. So all these are connected features, and these are the signs and symptoms of hypoglycemia in the earlier times as well as the later times. So that one should be keeping in mind, and always look out. You should be watchful in your patient and look out for this. Now let's move on to the management part. Now that you know the problems associated with this, now you know the investigation, what are the things that you should do. You also know to identify a patient in case the patient is having or developing signs of this hypoglycemic syncope. With that, let us move on to how to manage patients under diabetes or diabetic patients in a dental clinic. Number one, golden rules. Blood sugar has to be under control. When I'm talking about control, you see, patients, most of the patients, they do have this awareness that, if I tell the doctor that my sugar is not controlled, it's high, you won't get the treatment. They know this problem, so they won't actually reveal the real facts. They keep hiding. They tell, okay, don't worry, I've checked last week, or value was normal, doctor. You can proceed to the procedure. Do not fall into that. Okay, you always must be convinced with an evidence-based blood sugar control. You have to have a glucometer in your clinic or get a patient's laboratory report at that particular day of time or the day before. So that's what I'm talking about. And according to that, if the values are under control, based on the values what I've given below, well, you can take it for the patient for a dental procedure. Now, when I tell about taking a patients for dental procedure, what I'm talking about is surgical procedures. Okay, so patient can be taken for any non-surgical procedures, however high the patient's diabetic status is. This control of diabetes is actually required for any procedure in the dental treatment which inflicts or which creates wound, something like extraction. Oral surgical procedures all has to have a diabetic control. Flap surgery and other invasive procedures definitely have to have diabetic control. So all other procedures other than these, okay, can be taken up irrespective of the values of the blood sugar. So blood sugar need not be controlled in all other dental treatment other than all the oral surgical procedures and the surgical perio procedures. Okay. The second thing, golden rule, treat only after food. Make sure the patient has taken the food. If you have a history of this patient and patient is a diabetic, make sure you ask the patient whether the patient has taken food or not. Okay, should ensure that, and there should be adequate spacing. Now, morning appointments and is very important, because preferably, because once the patient sleeps, get a good sleep, your system is quite refreshed. The next day patient is waking up with a lot of fresh, and the system is not subjected to the daily routine stress. So that's the best time to do any extraction, because it's all connected. Most of these patients might be having associated symptoms or disorders like hypertension also. So body is quite well equipped and more prepared and more tolerant in the morning appointment. So give a morning appointment preferably. Okay, ensure the patient has taken medication, because patients diabetic blood sugar otherwise might go very high. You don't know actually. So make sure the patient takes the diabetic medication and taken in the right dosage. Should not have taken double the dose or anything of that sort. Whatever procedure you're doing, surgical procedure, you do it in a traumatic manner, because the more injury what you give for the patient is more amount of stress, the more amount of time. As you all know, they are prone for infection, they are actually having a delayed wound healing. So let us actually do a very gentle management of the tissues and give a less traumatic, or do an atraumatic procedure wherever possible. You can use a forceps extraction, or you can use your periotomes to make the extraction much more simpler wherever possible. So atraumatic procedure is actually a requirement for dealing with these patients. Compensate for snack time. A patient who has taken morning breakfast, say 7:30, and taken the diabetic medication, and coming to a clinic, and by 11:30, patients actually devoid of food to the stomach, but the effect of the drug is there and still in the body. So patient is prone for hypoglycemia. So in such patient, ask them to go have some food and come. Okay, so that's what I meant about snack time. Some snacks has to be given. Make sure patients have something in the food. So have some food, and the stomach is quite equipped to prevent the hypoglycemic effect of your drug. Preferably under antibiotic cover. When I talk about antibiotic cover, all diabetic patients do not actually require a prophylactic antibiotic treatment. Remember, if the diabetic values are on the upper range of the normal value, or what I've suggested earlier, if the HbA1c value is 7 or even more than 7, there are situations where the patient can come to you with a normal RBC, your random blood sugar, a normal fasting blood sugar, or within normal fasting blood sugar, and within normal postprandial sugar. But then those are all how that patient has taken the day before. A day before's diet and a proper fasting can actually give you this normal values. But remember, the probability or the chances of this patient undergoing infection is based on the patient's immune status. Immune status is very well assessed by your HbA1c value. HbA1c value more than 7 means patient's diabetic status is uncontrolled. Excuse me. So in diabetic patients with uncontrolled diabetes, patient has a tendency to become more immunocompromised. So even if you have a normal or relatively normal blood pictures value, what I've told about RBS, FBS, and PPBS, but if the HbA1c value is more than 7, definitely do take the procedure only with an antibiotic cover, and as much as possible try to get a little bit more steady management of the diabetic condition, then only take up. If at all you have to take up, it should be under antibiotic cover. So I've told you, if the values are like what I've told you in the previous picture, but if the HbA1c value is 7 or more than 7, you know that the patient's immune is weak. So supportive antibiotic prophylaxis is required before the procedure. Okay, the day before, at least 2 days before, you start off with the antibiotic and then do the procedure and continue for another 3 or 4 days. Excuse me. So that's about your antibiotic cover. All other situations, otherwise, if the values are abnormally high, again, and extraction or other procedure is very much warranting or indicated and must, in such situation also antibiotic cover is required. Okay. Chances of syncope has to be kept in mind, hypoglycemia related syncope, and that has to be how is to be managed. Again, I'll tell you, because it is something like your regular vasovagal syncope only. All these patients, they have the signs and symptoms of your regular syncope. Okay, that sweating, then sudden tremors, or little bit of hypotension, and then your tachycardia initially, then later on followed by bradycardia, and then lack of pulse, lack of volume of the pulse, and all the cold and clammy extremities, the lips getting pale. All these signs are classical of a vasovagal syncope. In hypoglycemia also, the similar type of signs and symptoms is the same. But the only difference is the history will actually reveal that the patient has not taken a morning food, but have taken a drug, an hypoglycemic drug, or any other situations, or too much time has passed after taking the food. So there's no food in the stomach. So that's again cause for hypoglycemia. So that has to be kept in mind when you think about it. LA with adrenaline has to be used with care. Make sure you don't give any intravascular administration, because intravascular administration pushes the adrenaline into the bloodstream and can create a hyperglycemic situation and worsen the condition that I've told you earlier. So these are the things that you should keep in mind in terms of managing the patients with diabetic or uncontrolled diabetes, or diabetes under control. When a patient comes to your dental clinic, any oral surgical procedures or surgical procedures of undergoing peri or whatever it is has to be taken in this consideration. All this has to be kept in place. Now with that management part, let us see a patient. Now I've told you about fasting blood sugar earlier. When I forgot to mention about that, when you talk about fasting blood sugar level, it should be a minimum of 8 hours fasting and then the blood. So night 8, hours of fasting, morning blood sugar, that's the fasting blood sugar value. Okay. Now let's see what are the problems associated with hypoglycemic syncope. We have diagnosed the patient with signs and symptoms, and the patient is there on the chair with hypoglycemic syncope. You have maintained the basic protocols of syncope, like put the patient a little bit flat. You have raised the lower extremities, and then slowly, the better pulse is improving. So if the cause, you have asked the patient, you have found out that the patient has not taken food but have taken medication of sugar, so hypoglycemia. So the reason is hypoglycemia. Then you're going to deal with the patient. Okay, so what are the things I'll be describing under three headings? One, if the situation is happening in an awake or alert patient. Okay, if the patient is awake and if the patient is alert and listening to your commands, then you can give 15 grams of glucose. You can either give a 180 to 200 ml of orange juice or a fruity or anything sweet juice. Then you can give glucose tablets or glucose powder. Okay, anything can be given. And then you have to monitor the blood glucose. That's why I said it's always better to have a glucometer in your clinic, wherein which you can cross check or monitor the blood glucose. And after 10 minutes, every 5 or 50 grams of blood glucose will raise the blood sugar level slowly. So that normal raise of blood sugar can be monitored with a glucometer if you have. So monitor blood glucose, and if there's not much of a sign improvement, repeat this particular glucose supplementation and 2 or 3 or 4 times, and let that till the patient recovers, till the patient normal signs are there but not feeling fully good. So until such situation, actually you have to keep on giving this glucose powder or liquid as in awake and alert patient. If the patient is uncooperative, sometimes I've told you in little bit of this if you have failed to identify the hypoglycemic syncope coming in the earlier stages, then patient might be gradually moving on to this uncooperative nature. So in such patient, you remember that you may not be able to fulfill the requirements. So automatically you might require a medical assistance or medical help. So always call for your medical assistant. You must have a contact with the neighboring hospital, an emergency department, where in case you happen to get some sort of an emergency, they will come to your assistance, or their ambulance will come to your assistance. And you can also administer glucagon, 1 milligram. 1 milligram glucagon, I've told you, can actually give a subcutaneously or intramuscular injection. Okay, and then you can also give this 50% of dextrose solution, about 20 to 50 ml of 50% dextrose. This can be given as an intravenous route. Your injection of glucagon is intramuscular injection, okay, or a subcutaneous injection, and this 50% dextrose solution can be given as an intravenous small infusion. Now this is all very much easy for you all if you get a little bit training in that. It's not at all difficult. I'm not talking about IV cannulation, but at least finding a vein, one of these median cubital veins out here, and just putting a small needle with the butterfly shaped scalp vein set, and giving this will actually definitely help you in saving a lot of emergency situations. Or if you have a trained nurse, definitely she will do the purpose for you. She or he, the trained nurse, will do this. So in uncooperative patients, always seek for medical assistance and administer glucagon 1 milligram subcutaneously or intramuscularly. And also you can give 20 to 50 ml of 50% dextrose, okay, intravenously. In unconscious patient, well, I've told you, you have already must be ready with the medical assistance people. The ambulance might be ready, and meanwhile, you can administer this 20 to 50 ml of 50% dextrose solution, because that actually suddenly boosts the blood glucose level in the body. I'm talking about a situation where there is a hypoglycemic area, okay, hypoglycemic situation. So this situation in an unconscious patient, if the syncope has arisen and because of a hypoglycemia, you should actually immediately summon medical assistance and administer 20 to 50 ml of dextrose solution. It's always best to have a well-trained nurse or nursing assistant in your clinic, because we are all prepared, or you should be equipped and trained and all these procedures to meet emergencies, because emergencies are inevitable in our practice, and one should be very well equipped, have a proper understanding to diagnose the situation as well as manage this condition also. So with that details, we have covered all the part pertaining to diabetes mellitus. We have also discussed about the various types of diabetes, the implications of diabetes, the problems associated with diabetes, and the what all problems you can have, you should face, how you should be prepared, what all you should be anticipating, the signs and symptoms of diabetes mellitus, and we have also seen the investigations and the normal values, and we have also dealt in detail about the management of diabetic patients, how to deal, when to deal, what sort of medications are required, when to give antibiotic, when not to give antibiotic, prophylactic antibiotics is needed or not, and we have also ended up with a detailed management part about this patient who's having a hypoglycemic syncope. I hope everything is clear for you. Thank you for your patient listening.